Next, we're going to talk about how we might actually go about diagnosing psychological disorders. So, a classification of these disorders is a pretty necessary first step when we're trying to figure out the nature, the causes, and how best to treat different psychological disorders. We kind of have to label them and diagnose them to figure out what to do next. But how do we decide the best way to diagnose these disorders? For a diagnosis to be good, we want something that is both reliable and valid. When we're talking about reliability, this means that different clinicians using the system should all show high levels of agreement in their diagnostic decisions. Basically, we're saying that the system should be based on things that we can observe, things that we could track and view to try and figure out the diagnosis, and that we should try and not rely on subjective judgments. So if we're relying on things that are observable, and we rely less on the opinions of clinicians, then we should have a lot more agreement between different clinicians using that same diagnostic classification. So if we want something that's reliable, we want to make sure that we're getting lots of consistency between people, lots of agreement between people. When we talk about validity, we're looking at that diagnostic categories should accurately capture the essential features of the disorder that you're trying to categorize. So if we're talking about a particular disorder that has three very distinctive aspects to it, then our method of diagnosing that disorder should also have three very distinctive aspects that it's looking for. And if we have something that is valid, not only will it capture those essential features, but it should also allow us to distinguish between different disorders. So it should be specific enough that we can tell disorder A from disorder B if we're focusing on the features that matter to tell them apart. Now, this discussion of what makes a good method of diagnostics brings us, of course, to the DSM-5. And the DSM-5 is the most widely used diagnostic classification system in North America. Now, there is a caveat here where it's specific to North America. So the DSM-5 is used pretty much exclusively in the US. In Europe, you're going to see what's called the ICD-11. And in Canada, you kind of see a mixture of the two, which makes sense. Canada has lots of influences from both Europe and the US, so we're a little bit of a mix of both. But the DSM-5 is probably what you're going to encounter most often, and it's what you see talked about most often in universities here. So that's what we're going to focus on, and that's what I know about. So, if you're interested, I'm sure you can look up the IDC-11, and it should be fairly similar. Now, for those of you who think like I do, I wanted to know what DSM stands for, and strangely enough, our textbook doesn't tell us that, so I looked it up. And it stands for the Diagnostic and Statistical Manual of Mental Disorders. So, as you can imagine, DSM-5 means that it's the 5th edition of this manual of diagnosing psychological disorders. And this 5th edition is actually recent enough that I remember it being rolled out. So DSM-5 came out in 2013, replacing the DSM-4. Which, again, if you're interested, instead of using the number here, it used to be IV, so the Roman numeral for 4. For whatever reason, they decided to change to numbers for this one. But this comes from the American Psychiatric Association, and they released the DSM-5 in an attempt to make a better manual to revise and improve how we were diagnosing psychological disorders. Now, the old system, the DSM-4, was a categorical system. So it was basically trying to place people into categories based on different symptoms or behaviors that could be observed. So as you can imagine, with categories, people had to fit within a particular box to get a specific diagnosis. And that led to a couple of downsides. So, as you might imagine, the criteria to diagnose individuals in a categorical system ended up being so detailed and specific that as many as 50% of people being assessed ended up not fitting into any of those categories properly. So it became really difficult and kind of convoluted to try and diagnose people under that old system, which led to an overhaul that gave us DSM-5. And so the big thing about DSM-5 is that they went from being categorical to instead being more on a spectrum. So this new system, it didn't completely get rid of categories. So there are still some categorizations, but there's also that important addition of sort of existing in a spectrum of how intense different symptoms are. So that's where we get this dimensional component. So we're not simply looking for the presence of a particular behavior. Now we're starting to look at the severity of that behavior as well. So is it there? And if so, in what degree? So if we wanted to talk about an example of this dimensional approach or a dimensional scale of rating behaviors, we can look at table 16.2 from the textbook. I'm just going to read you a little snippet from that. But you can have this evaluation of if you are simply a conscientious personality at sort of the left side of our scale, all the way up to obsessive compulsive personality disorder, which is the extreme on the right-hand side of the scale. So you can range from if you are a conscientious individual, if you have that personality trait, you can say, I do what I'm supposed to do. I have a strong work ethic, and I take pride in my work. I like to take my time and do things right. So that's, you are a conscientious person. You take pride in your work. Cool. If we go to the other extreme, though, if we have someone who is severely disordered on that obsessive compulsive personality disorder, they might say something like, I check and recheck my work until I'm sure that no one could find fault with what I've done. I can't stop worrying that it's not perfect. So that's the other end of the spectrum where it's starting to cause problems. People are obsessing over their work. And there's degrees in between. We can look at people who are subclinical or disordered, but not severely so. But it exists on a spectrum. Now, if we want to talk about the actual diagnosis process, I want to get back to this title where it's integrating both the categorical and the dimensional approaches. So integrating the DSM-4 and coming into the DSM-5. So the next couple of slides here are actually using the 5 axes or the 5 sort of subsections that were included with each diagnosis under the DSM-4. So for DSM-4, if you received a diagnosis, there was talk of the first axis is your clinical symptoms, basically any kind of psychological disorder that didn't fall under axis 2, which we will come to in just a second. But this is like the meat and potatoes of your diagnosis. So which box did you fall into? Do you have depression or schizophrenia or social phobia or whatever? So that's usually the big thing people are looking for. But the DSM-4 went on to Axis 2, where they talked about things like developmental and personality disorders. The idea here is that having a developmental or personality disorder can kind of modulate the symptoms of your actual diagnosis. So these can confound things just a little bit. And so this is where they'd note things like autism or an intellectual disability. Things that are usually seen earlier on in childhood and then carry on throughout the rest of your life. This is where you'd also get personality disorders. Come back to personality disorders just a couple of slides. But this section is basically looking at long-lasting disorders, things that are going to encompass your way of interacting with the world. So if you have a particular type of personality disorder, maybe you're going to have paranoia, maybe you're going to be antisocial or something like that, and it's affecting how you interact with the world. So this is sort of an add-on to your sort of clinical symptoms that lead to the sort of big box diagnosis. And then axis 3 is where you have physical conditions, so things that may be contributing to or potentially causing some of your behaviors. So things like if you had a brain injury or HIV/AIDS or any other kind of physical condition that can cause or modulate those symptoms of mental illness. Now, sections 1 through 3 ended up kind of being combined into one for the DSM-5. So all of those aspects, all of those different contributions were assessed all at once using the sliding scales of the DSM-5. I'm not going to go into tons of specific detail on specifically how they diagnose people with the DSM-5 because there are entire classes on clinical psychology that have to go through teaching you that. So we're going to keep this pretty low detail. For the DSM-4, they continued on with axis 4 and 5. 4 talking about the severity of those psychological stressors. So what was going on in your life that might be stressing you and making these symptoms worse. So death of a loved one, starting a new job, unemployment, marriage, things that could change how you're interacting with your world. And then 5 talked about your highest level of functioning. And this was basically a scale of 0 to 100 to talk about how well you were interacting with the world. And this was an interesting scale. I looked this up because, of course, I was curious. So the lower you score, the less capable you are of functioning on your own. So if you scored 10 or less, you're someone who physically can't function on your own. You should be supervised. You are potential harm to yourself and others. Someone should be supervising you. If you score at the higher end of the scale, if you're 90 to 100, then you're perfectly fine existing on your own in the world. And the DSM-5, the newer version, took these and sort of included them as footnotes to tack onto their big diagnosis that included the first 3 axes. So basically the same information was present, just they got it in a different way. They got it through their axes and their degrees of severity, but same basic information overall. So just a little bit of an aside there to explain kind of what we're looking at here. And so if we want to talk as detailed as I can get about the actual diagnosis process, let's use the example of personality disorders. So we've already spent a chapter talking about personality, so we kind of remember, I hope, the idea of the big 5 of personality and how we can exist on those 5 different scales, and those 5 different scales give us a pretty good representation of human personality. Now, the idea of the DSM-5 is that our potentially disordered behavior, this abnormal behavior that we're diagnosing, isn't so much behavior that's separate and living out on its own and just happening. It's actually more of a extreme of natural behavior. So we're saying that disordered behavior is an extreme of normal behavior and not in its own category. So in that vein, that's why we're picking to talk about personality, because we have the background of personality. You might notice that some of these terms that we're evaluating to try and figure out personality disorders are pretty familiar. So things like introversion. We talked about that scale of introversion to extroversion in normal personality. But for our other scales that we're looking at when evaluating personality disorders, we can look at negative emotionality. So one end of the spectrum is negative emotionality, the other end is positive. So if you score high on negative emotionality, you're experiencing distress, you have anxiety, depression, that sort of thing. We can also look at schizotypy, which is basically odd or unusual thinking. So the same root of schizophrenia, where it's disordered and odd behavior and thinking there. We can have disinhibition, where if you're scoring high in disinhibition, you're very impulsive. You're not inhibited. You're irresponsible. You act out. We already talked about introversion, but at the extremes, we'd be looking at withdrawing from society, avoiding having relationships with people. We can also have antagonism. So if you are callous and manipulating and hostile or aggressive, that's antagonistic. And then compulsivity, if you're looking for that rigidity and perfectionism, like we talked about the example of obsessive compulsive personality disorder. But this figure here actually only looks at two specific personality disorders. Borderline type, so if people score high in negative emotionality, high in schizotypy, and high in disinhibition, they end up categorized as borderline type for personality disorder. Whereas if you score high in disinhibition and antagonism, then you might end up under antisocial or psychopathic type. And this is the part where the DSM-5 really shines, because this is sort of our broad category, but we can also look at the intensity, so how high is high for these scores, to give us a better idea of what that individual is experiencing. So not everyone who falls under the broad diagnosis of borderline type is going to have exactly the same behaviors, which we can capture with that dimensionality of the DSM-5. So some people are going to be extremely high for the negative emotionality, but maybe only sort of high for the other two. And that's different from someone who's extremely high on disinhibition, but only high on the other two there. So a little bit more personality and customization, which is especially important when you start looking at things like treatment, which comes up in the next chapter, where the more you know about an individual, the better you can treat their disorder. Now, this, albeit vague, idea of having a diagnosis or diagnosing an individual may sound all well and good, and like we said at the beginning, you really do need a diagnosis to be able to start treating people in a lot of cases. We have to consider that there could be some critical issues that come along with having a diagnosis. So, along with a diagnostic label, there come a couple of other issues, some social and personal issues, some legal issues. So, let's talk about a couple of those. So on the social and personal side of things, if somebody receives a label, if someone is diagnosed as having OCD, it kind of becomes really easy to accept a label as a description of a person, as that individual is OCD. But not all people who are OCD are the same. People are not just their diagnoses. And so, as we've talked about a lot in this course, because it's a psych class, people really like shortcuts. Our brains are hardwired to find shortcuts, which is why we rely on stereotypes and things like that. And this is one of those situations where it can be really detrimental to have that, because we tend to have sort of a mental image of what it means to be OCD, and all of a sudden you try and make someone who tells you that they're OCD fit into the box of what you think someone who is OCD is. And so that's sort of an individual's interpretation of someone who has been diagnosed something, but it can also work the other way, where if you are told that you have a particular diagnosis, then you might also feel like, yes, this is the box into which I fit. I am my disorder. This is how I should act. So people may start accepting the new identity that's implied by the label they've been given. Yes, I'm OCD, therefore I act like this. This is who I am, this is how I am. And as we know, we're really good at making our expectations a reality. So we might start developing that expected role and how we view the world based on what we've been told we should be. So, complicated issue there. And there's lots to it. It's a very interesting topic. In terms of legal sides of things, I'm not quite sure why I have the title here twice, but for legal consequences in two different lists that are whatever, they're lists. You can things like involuntary commitment, where if your diagnosis includes the label of you are someone who is potentially a risk to yourself or others, you can fall under that category where you could be committed. You could be sent to a mental institution against your will because you've been deemed mentally unfit to be out in the world. And that can go along with things like your loss of civil rights. If you've been deemed mentally unfit, you won't be able to vote. You won't be able to make decisions for yourself, that sort of thing. And this commitment can lead to indefinite detainment. Somebody else has to decide that you no longer fall into that category in order to be released from that commitment. So it can be troublesome. So legal consequences. You can also look at things like competency. Should you be left to care for yourself? Are you capable of taking care of yourself? If you've been put on trial for a crime, is it because of your diagnosis? Is it some other thing? So we can start looking at competency in terms of, were you capable of making the decision to commit that crime, or are you not guilty by way of your mental state or your diagnostics? There's also the question of your state of mind at the time of a judicial hearing. So if you go to court, you might not be deemed fit to stand trial. You might not be able to testify for yourself, again, because of whatever label you've had. So you could be found not guilty by way of insanity, and then you end up committed, kind of leading us back to the first half of this inexplicable list. And they're trying to figure out your state of mind at the time the crime was committed and all this sort of stuff. So there's lots of complex things that come along with once you have a diagnostic label. So interesting to consider.